going to move to our first panel discussion of the day now, which is entitled Evolution of Arthritis Treatments, the Model of Care for Rheumatology and What the Future Holds. And I'm delighted today to be joined by our three guest speakers. First of all, we have Professor Geraldine McCarthy, who's consultant rheumatologist at the Mater Hospital in Dublin. You're very welcome, Geraldine.
Thank you, Grania. It's a pleasure.
And next we have Professor David Kane, who's consultant rheumatologist and HSC clinical lead for rheumatology.
Thanks very much, Grania.
And then we have Peter Boyd, who is our services support officer in Arthritis Ireland and who also lives with rheumatoid arthritis. So you're very, very welcome and thank you for taking the time to join us today. Geraldine, if I can start with you, can you tell me what an arthritis diagnosis looks like today? Versus 40 years ago, and what medical advances mean to a person with arthritis, their prognosis today?
Incomparable to 40 years ago, say. Yeah. When I started my exposure to rheumatology, which is embarrassingly long ago, when people would be diagnosed with, say, rheumatoid arthritis, for example, really the drugs were very limited, and so you would take drug number one and increase the dose until you decided, not great. Same, drug number two. So it was all down to rehab and joint replacements and all of that kind of thing. And also, concurrent with that, poor disease activity management, there was a then unappreciated increased risk of cardiovascular disease and stroke. So, when we're talking about rheumatoid, it is a systemic disease. Now, you've made the point about arthritis being many things. So I'm just using rheumatoid arthritis as an example because that's where drug discovery has been amazing. So in comparison to that, nowadays, if somebody comes to me with a diagnosis, I make the diagnosis of rheumatoid, what my plan for them is that the only reason they will know they have the disease is that they're taking medication. Now, obviously, that doesn't work as well for everybody, but the majority of people, we can really give them back a good quality of life and they can continue to work and so forth. So it is incredibly different. And another concurrent condition that I think has had amazing developments is osteoporosis, because an awful lot of our patients with rheumatoid would have been managed with steroids because, again, we were so limited in the drugs that we had. And then their bones would crumble, and if you had crumbling bones, nothing you could do about it. Whereas now, if you get osteoporosis, we can actually fix it. So, the landscape has changed utterly, I would say.
And can I just ask, given that you mentioned osteoporosis, because I think one of the areas, maybe when we talk about the significant advances that have been made in relation to maybe inflammatory arthritis, sometimes, when we look at osteoarthritis, what would you have to say about developments in terms of osteoarthritis? Because it would appear that there have been less, I suppose, significant advances in relation to the treatment of that disease.
Sad to say, Grania, and osteoarthritis is the most common form of arthritis occurring in human beings, and it is getting worse because people are living longer. The obesity epidemic is really exacerbating it, and we'll, I'm sure, talk about that later in this discussion. So sad to say we're still very limited in osteoarthritis. Now, I think there are things we can do. Obviously, the weight loss can make a huge difference in people who are overweight, of which the majority are these days, sad to say. But we can, there are various medications we can do to help pain. Physiotherapy is extremely important. Exercise is extremely important. So there are things we can do, and then when it comes down to it, joint replacements have advanced hugely. So it's not that we can't do anything, but I think we need an awful lot more drug discovery. And the problem with osteoarthritis is it's a little slower in developing, so rheumatoid can come on over a few days, literally, or a few weeks at least, whereas OA comes on much slower. So it's very hard for the drug companies to get a quick fix from their drugs when they're developing them. So from a business point of view, it's not very attractive. They did research these nerve, I can't remember exactly what they were called, but anyway, they targeted the pain of osteoarthritis by a nerve growth factor inhibition or something like that. And of course, that caused worse osteoarthritis. So attacking the pain by itself, it was a bust. So we were just back from the ACR, and really there aren't any huge developments. But I think with time we'll get there. But an awful lot more work needs to be done. But meanwhile, I think we have to target marketing to children of junk food. I mean, it's an enormous problem.
Okay, thank you. David, if I can move on with a question for yourself. So the overarching aim of the model of care for rheumatology is to facilitate a right person, right place, first time approach to treatment. Can you tell me about the care pathway developments for arthritis and the progress that's been made to date?
Yeah, I think Geraldine alluded to it in that the number of people who identify with arthritis is huge. I mean, we're talking about perhaps 1 million people identify as having arthritis. 400,000 people have osteoarthritis, the commonest disease, and smaller numbers, but quite significant numbers, have inflammatory arthritis, which Geraldine was talking about, where we've made the biggest breakthroughs. So why do we make the biggest breakthroughs in inflammatory arthritis? Because they were the most severe diseases. They hit you younger. 50% of people who would get inflammatory arthritis in the past would have been out of work within 5 years and disabled. And now, with the advances, the drugs that we have, we're able to maintain people in pretty normal lives if we can get them treated early. So right person, right place, right time means we need to get people with inflammatory arthritis into the system a little bit faster to get them on those drugs, because the drugs work best at an early stage. So we're trying to create fast-track ways into rheumatology services for that. Unfortunately, as Geraldine said, a lot of other forms of arthritis, the treatments are more at a primary care level: physiotherapy, painkillers, and what you do, education. I mean, Arthritis Ireland is a fantastic organisation for educating people, because the worst thing about having a pain in your joint is not knowing what I should do. Should I get up? Should I move? Should I sit still? Should I rest? It's frustrating. It brings anxiety. It brings depression. It all adds to the problem. And you know, the education is paramount. And so meetings like this are great. But we want in the programme to, you know, develop more and more access to services in primary care for those treatments that are delivered in primary care. We all hope that, I mean, we've seen such breakthroughs at rheumatoid. Eventually that will happen with osteoarthritis, but it's not happening yet. But I mean, if you worked in rheumatology 50 years ago, it was frustrating to be in an ankylosing spondylitis clinic and just push another prescription for an anti-inflammatory across the desk to somebody who wasn't really getting relief from it. Now you have drugs that effectively cure that disease. And I think you wouldn't have believed it would happen 50 years ago. So I think these things will come with osteoarthritis in ways probably that we haven't worked out yet, to be honest. We're still trying to develop drugs for osteoarthritis in the way we develop drugs for rheumatoid, and it hasn't really worked yet. So the model wants to, number one, increase the number of specialists. So we worked with the National Doctors in Training Programme, who agree that we need to double the number of rheumatologists. We're about 30% of the way there since I started working with the programme, so we have more work to do. But not everybody needs to see a specialist, so we also need to get people better access to community services such as physiotherapy, obesity programs, education. And most of the drugs for the more common forms, such as osteoarthritis, are delivered through primary care. So that's the way the program wants to work, is get you faster to the treatment you need by making sure we're not all queuing to see a rheumatologist, but perhaps get in quicker to the person who can give you help with your problem.
Okay. Peter, perhaps I can come to you next. You were diagnosed with rheumatoid arthritis, when you were 27 years of age. Can you tell me about the improvements in treatments that you have benefited from as a patient, and the impact that this has had on your day-to-day life?
I think it's important to notice that the huge impact. Tim mentioned it earlier on, that it impacts on every aspect of your life. David mentioned that 50% out of work within 5 years of being diagnosed. I was one of those people. I was diagnosed. I didn't know what to do. I was afraid of moving or not moving. I was unknown to me what I could do, what I couldn't do, what my management was going to be, how I was going to cope, all the anxiety, stress, depression, and everything else that came with it. And that was at the very beginning. I left my work, I left jobs, I left relationships and everything else like that went with it. And then the change happened when the medications came in that could actually work and be beneficial. And now the medications are working, and all the things that I didn't think I could have at that point when I was diagnosed, like a job, like a family, like I'm even back playing five-a-side football. You know, like it's to that point. And I know that's not the experience for everybody, and I know that's not going to be everybody's story, that they're not able to do that. But I've got to the point where I take my medication, and that's what I'm able to do, and I'm able to carry on with my life. And it's as Geraldine said, that I know I have arthritis because I take my medication. I do have my flare-ups. I do have the moments where I have to take it easy and I have to slow down for a while. I had one about a month or 6 weeks ago, excuse me, and everyone in the office knew about it because my hands were swollen. I was a bit more lethargic. I struggled a bit for a time, but I was able to, in normal, regular life, I was able to do those things and really get enjoyment and satisfaction. Whereas at the beginning, when I was diagnosed, I saw no future for myself. And it's not too heavy to say that without a combination of Arthritis Ireland and the services and the right medication at the right time for myself, I wouldn't be here. And that's how important the right medication at the right time is for people. It's that critical.
And can we share with people listening that Peter became a dad for the second time in the last 2 weeks, so he's
yeah.
So I think just to that about your just about that, you know, that positive that your life is in a, you know, a good place at the moment.
When I was diagnosed at 27, I saw no value in my life. I presumed that all that was ahead of me was joint replacement surgery, going into a wheelchair, not having any future whatsoever, being a burden on any potential partner or any potential relationship in the future. I actually broke up with the girlfriend I was seeing at the time because I didn't see any point in burdening her with my arthritis. And it took a long time to get back to confidence and to realize what I could do. And, you know, I couldn't be in a better place than I am right now. And that's, as I say, it's down to the medication, but it's down to hard work as well and services, you know, that we offer.
A combination
Of everything.
Yeah.
And it's combination therapy, it is medication, but it's also services and supports.
Thank you for sharing that with us. I appreciate that. So moving on, Geraldine, in recent years, we've seen a further development in the treatments for arthritis, you know, in the introduction of biosimilars. Can you tell me a little bit about, you know, the affordability and, you know, the economies of scale of these biosimilars, you know, in terms of the positive impact they've had on rheumatology services for people?
Well, I'm no economist, and I'm not a pharmacoeconomist, so I can't tell you the exact numbers, and I'm not sure we even, as doctors, get informed about that, but there's no doubt about it that the development of biosimilars has made the use of these drugs much more affordable to the government and to the exchequer. I know that in the UK, if as a rheumatologist you want to prescribe a biologic for somebody, prior to this at least, and I think it still is the case prior to the biosimilars, you have to get 2 different people to agree, and then you have to go signing form. Anyway, it's a production. We've been very lucky in Ireland heretofore that if in our clinical opinion somebody needs a biologic drug, we can prescribe it. But I was really concerned that we tend to follow the NHS a bit in Ireland, and I was afraid that we were going to get to the point where we'd have to do all those form fillings and stuff to prescribe these drugs for our patients. So I think the arrival of the biosimilars has put that fear out of my head, at least. So it's just made a management of inflammatory arthritis less burdensome from a financial point of view. There's no doubt about that.
Yeah.
I mean, there's some conditions that the biosimilar, even though no 2 biosimilars are identical, as are no 2 biooriginators. And we have found, anecdotally, the occasional patient who will feel they're not doing as well on their biosimilar as their biooriginator, but that would be the absolute minority. Most people do absolutely fine.
And David, from your point of view, anything to add to that?
Yeah, I mean, I think we sometimes forget that another big advancement in rheumatology was we learned to use the drugs we already had, like methotrexate, better. We sometimes forget that. It's still a good drug. And we do, I don't want to give everyone the impression that, it has to be a biologic or nothing. I mean, many patients will manage very well on the existing drugs, which are now used in a much better way, I think, and we see a lot less side effects with them. The biologics, big game changer in inflammatory arthritis, but only inflammatory. They don't work for osteoarthritis. They don't work for fibromyalgia. They don't work for gout. That's not where they work. So a lot of people come in looking for them because they've read about them on the internet. And they made such a huge change we heard it so eloquently from Peter, they make such a huge change to people's lives. The biosimilars are exactly the same. They are, there's been a lot of confusion about, the technology of it. But if we look at Geraldine and I were both at the same conference recently, and they presented huge amounts of data on switching that went on internationally. Countries like Denmark, they just switched everybody. You turned up to get your prescription, and you didn't have a choice. The switch had been made for you. And they really saw very, very tiny numbers of people saying that they felt worse on the new drug. In Ireland, we've tried to engage with our patients, educate them, get them to feel comfortable making the switch. And if people do flare, we can switch them back. But I really would encourage anyone who is on an originator and who hasn't been on a biosimilar to make that trial of a switch, because it's a huge economic saving, and there's a finite amount of money we have to spend on health. We spend about 1.2, 1.3 billion a year on high-tech medicines, and there's lots more coming for people who need other drugs. But we can't afford them if we waste money on, drug A that costs twice as much as drug B, but they do the same thing. And they really do the same thing. So I'd really say that's the message we need to get out, is that if you haven't made the switch, to try the switch. And we do have the ability to switch you back if it really isn't the one for you. But in our practice in Tala University Hospital, we found it was less than 1% of people approached us about making a switch back. And most of them, it was a bit more of a subjective. They just didn't feel the injection device, or it wasn't right for them. But we didn't see many patients having an actual flare, to be honest. And then again, you don't know if they're having the flare, would that have happened anyway, whichever drug they were on.
Yeah.
So definitely it's been the big change.
And David, another question for yourself.
Okay.
So in terms of the medical advances that have been made in recent times and the management of rheumatic diseases, are we providing services to all those who would benefit from it, and particularly in relation to, I suppose, early diagnosis and treatment?
Well, the answer is we're not, because of capacity. That's why we want to double the number of rheumatologists, and we want to create fast-track pathways in to get people with inflammatory arthritis in. But we're using the National Musculoskeletal Physiotherapy Triage Program, so that we can maybe get patients who have non-inflammatory disease seen by a very skilled physiotherapist and diagnosed with osteoarthritis or fibromyalgia, educated and started on treatment much more quickly than if they waited to see an orthopedic surgeon, which would be inappropriate in both those cases where they don't need surgery, or a rheumatologist, where perhaps all we're doing is the same as the physiotherapist. Now, we do have, ultimately one day, and I really hope this will happen, because as we all get older, we hope there's going to be better fixes for osteoarthritis. But one day there will be better treatments for osteoarthritis, and maybe then we'll be seeing a lot more patients as rheumatologists. But at the moment, the important bit is increasing access to a specialist to tell you what's going on and how to treat it. It's terrible to see people who've been waiting a long, long time, getting ingrained in very difficult ways in their life, And I bet when you came first, you were kind of resistant to some of the information in a way, because you kind of had to work it all out for yourself.
Exactly.
And you were getting frustrated, and you didn't want this smart ass telling you, do this, do that. You were kind of, you've developed your own coping strategy. But if we can get you earlier, it's much easier to work with you to change the
like take a seat down there, and you can just answer my questions.
but you know what I mean?
Yeah, you're right. You're so right.
The tough thing about it is it's so easy when you get people at an early stage to fix problems, and sometimes when you get at a late stage, you're just as frustrated as the patient.
100%. Yeah.
A follow-on question from that really is, look, we know in Ireland, we have an aging population. We know that we're on trend to have our population is aging, and given what we already spoke about, the increasing likelihood then of developing arthritis with age and with the other kind of lifestyle factors that we've talked about. How is our health system? Is it prepared for this, or how can we gear it up to deal with this?
We don't need to increase specialist capacity for getting people to exercise. We don't need to increase specialist capacity for trying to get people to eat well and to change things as, you know, we've had attempts such as the sugar tax, controversial it was, but to change the ways that we're developing obesity, which is a big problem for knee osteoarthritis is the commonest form of osteoarthritis. And obesity is a big determinant of knee osteoarthritis. So aging, obesity, you know, we can't deal with aging, but keeping people active and healthy is going to maintain muscle strength and joint flexibility. But yeah, we don't have treatments to stop time yet. But I think the main thing is we should be educating that population health is going to be critical. We have a national program for obesity led by Donald O'Shea doing amazing work trying to roll out community programs to help those who unfortunately have become morbidly obese. We've got to get the message out about exercise. All our national sports organisations, FAI, RFU, GAA, have got injury management programs now so that you don't get people to over-exercise on an injured joint, you give it time to recover, because that can lead to arthritis later in life. So we've made huge strides, but a lot of it's going to be at community and primary care level.
Because isn't it sometimes people may know that they are overweight or that they're not eating properly, but it's making that shift to, you know, they're changing their behaviour around physical activity or eating well.
And knowing that it's safe to exercise as well, you know, that people often fear, particularly osteoarthritis. One of the biggest misconceptions with osteoarthritis is the way, or not misconceptions, but poor communications is the way we focus on the idea of wear and tear. And so people say, oh, I better not use that joint. But actually, if you exercise on an osteoarthritic joint, I'm talking about light, regular exercise, not heavy, intense bursts of exercise. It keeps the muscle strength, which supports the joint, particularly for the knee. Quadriceps exercises are critical. It keeps the flexibility, and it eases pain. And it keeps your weight down too. So, I mean, it is important to get those kind of messages across.
Okay. Peter, back to you. As somebody living with rheumatoid arthritis, have you experienced the first-hand, you know, impact of, you know, the strain in our health services, and how has that impacted your health and well-being?
Immensely. It has done. There's a couple of difficult stories of like that, trying to get appointments. You might not see the same person, so you're having to repeat your story. And you know, for somebody like myself, who's I'm 12 years now, and going back to the very beginning to start your story and repeat everything that's gone on. Somebody who's living with it for 20, 25 years, what do you say to somebody who's completely fresh to your case? But then also just trying to get appointments. If you're relatively well managed, and you might be pushed out a bit longer because there's so many other people needing to be seen, then you have a flare and you can't get back in. There's so many other things. Then also trying to get to see a physiotherapist or the primary care, because they're so stretched as well. I know that physio or exercise is so important, but trying to get that appointment so that you're doing it correctly, getting to see the physiotherapist so they can show you the exercises and do it right. All of these things are important, and it makes it very difficult. There's also the difficulty then what we've had with the pandemic of remote calls and doing things if you don't see the person in front of you. For what's funny now, but we're talking about obesity. When I was doing a call over the phone, my height and weight was miscalculated, and I was told that I might need a gastric band because my BMI was I was morbidly obese, because it was misread on the scale when it was done. And I got off the phone and cried to my wife. I'm not morbidly obese, but because it was a rheumatologist that was saying it to me, and I was so caught up in the emotion of the phone call, I just was overwhelmed and said, oh, well, this must be true. And this must be something that I need to do, because I was a bit heavier than I am now. I'm trying now to get the weight back down because I know it's important. But that was how invested I was in the phone call, and I had to wait about 15 minutes for the phone call to come back to go, hold on, I've miscalculated. You are overweight, but you're not in that state. And that's funny in one sense, but it shows how anxious and upset that we can be as patients. That I knew something about myself, I was told something else, and it totally threw me back into that nervous, anxious, depressed person that I was way back at the beginning when I was diagnosed, and it overwhelmed me and it just threw me completely. And that's what we have to be so careful about with the strain, because we're talking about people who are they're under pressure. You know, the guys here who are seeing so many patients on a daily basis, they're under strain and under pressure as well, not just getting appointments, but when they're in the clinic. So, you know, mistakes like that, miscalculations are something. So we as patients need to be aware of that as well, that it's a team, it's a working together so that we can get ourselves better. Not it's, as you said earlier, you know, the person talking down to you and explaining, you know, this is what you have to do, this is what you can't do, and you're just totally swamped with information. So there's so many areas that the strain of the medical world can put on you that it's difficult to navigate, and that's where we need our support, we need our helpline, we need people to come and talk to us, we need to go out there and get the people as they're diagnosed, so they're referred to us so that we can talk to them and talk them through those initial stages.
And I have to say, just listening to that, I mean, clinics are such a short time. You know, you have really small objective, you know, tight small objectives, and what I get in terms of the overall education is I get such good feedback from patients who do your self-management course. You know, the Arthritis Ireland self-management course gives you much more space to kind of take on board all of this, because in 5-10 minutes, you're trying to throw so much information at somebody that, you know, and hope some of it sticks. It's just not a very effective communication when we're stuck with so little time because so many patients in the system. So I would put a big plug in for your self-management course.
Thank you for that.
Yeah.
And on that topic of kind of lifestyle modifications, Geraldine, you know, we've talked about, you know, exercise, physical activity, healthy eating, weight management, and we know that they are hugely important. Does patient involvement and self-management play, you know, a role in the management of arthritis in order to improve outcomes for patients?
Does it play a role? I'd say it's absolutely essential. And I think it's really important from the get-go that we communicate that to the patient and make them have ownership of what's happening in their lives. And obviously, for prescribing medication, there's the whole education piece around that. And this is where our nurses are very important, actually. When I prescribe a drug, then the next step is they go talk to our nurses who tell them, you know, all the information they need about the drug, give them written information about the drug, and organise blood tests and all of that. So right there, you've got the self-efficacy about either taking a medication or not, because actually there is a proportion of patients that aren't adherent to the medication, either fear or not liking medication, or the neighbour said this is dangerous or whatever. So there's all of that. But then you've got the lifestyle part, the exercise and the weight. And I suppose I hate going on about it, but the number of people that come into me with widespread pain, actually, that is driven by the fact that they've put on 3 stone in the last 5 years, type of thing. And actually, when you bring it up and talk about it and show the data, people are remarkably accepting of it and kind of, I was thinking that myself. And, you know, you give them specific advice on what to do. For example, the one I send people to is Slimming World. I have no shares in Slimming World, but at least it's a specific thing that people can do. And I've been very pleased, actually, at the reaction of many of my patients. I had a gentleman in recently who his BMI was 48. Like, that's really very, very high. And so he came back to me 3 months later, and he said, I've been doing well on the weight. And he had lost like 10 kilograms or something. I said, wow, that is amazing. And he said, well, you put the wind up me. Now, I didn't mean to do that, but he wasn't angry with me. He was like...
He was probably thankful.
So I think it's up to us as clinicians as well, because it's happening imperceptibly. It's scary. If you look down any street, how many fast food stores do you see, or restaurants, and they're making money, and more of them are coming. Who's buying that stuff? So we're all being hoodwinked, I think, into buying those things. And could I just mention gout? Would you mind if I mention gout? Because we don't have gout is something that is a very serious inflammatory arthritis that there's a bit of a stigma about, and people are under the impression that if you have gout or think you've gout, it means that you're you live badly, you drink too much, you're a kind of a bad person overall. And patients have told me this, and in fact there's a huge genetic predisposition to gout, and it's being very badly managed worldwide because either patients aren't coming to the attention of clinicians, the management of it is very poorly understood. It is associated with what we call the metabolic syndrome, so you've got hypertension, diabetes, obesity, and all of that stuff. So I just want to make a shout out for gout. I'm sure hardly anybody in this room is even at risk of it, but if there are people online or could pass it on, if anybody thinks they have gout, please do something about it, because it is associated with premature cardiovascular disease and strokes.
Okay, thank you for that. And I think just back to your comment there about weight management, I think one of the statistics we sometimes quote is, and I hope I have this right, it's for every pound of extra weight that you're carrying, it's equivalent to 4 pounds of pressure through your knee joints. I think I have that right. So in terms of your knee, the load on your knees, even small changes in weight can have a huge impact.
Yep, a few kilograms. And actually, that gentleman I referred to, he already felt benefit in his knees.
Sometimes if people have a lot of weight to lose, it can be hard to get started, because you say, well, it's actually, I have such a mountain to climb here that, will I start at all? But actually, I think the message is even small changes. Start small and gradual.
Start small, exactly.
Peter, you were speaking there about referrals to the helpline and that, so I'm just going to ask you a question around that. How important do you believe that referrals to Arthritis Ireland are, and how has the relatively new clinic referral program made an impact, and it made an impact in terms of providing people, with access to services, such as our self-management programs, when they most need it. You might speak to us a little bit about that.
Yeah, so the clinic referral program I think is a massive opportunity and a huge benefit to people. So this is a way for people who are going to their clinic to be directly referred into Arthritis Ireland, to get a call from us as an organisation, from our helpline staff. And it just makes that difference of, we were talking about the initial appointment where people are bombarded with information and they're given lots of things. They might be handed a leaflet and they might be handed the phone number of Arthritis Ireland. But I can guarantee most people, when they do that, they get the phone number, it goes in the handbag or in the pocket, and it's forgotten about and what have you. What we do with the clinic referral program is, instead of it being the onus being on the patient to have to make the phone call, the clinicians or the nurses, we talked about the nurses outside, the physiotherapists, whoever it is that is seeing that patient in the clinic, makes the referral directly into Arthritis Ireland. So while the patient is sitting there in front of them, they talk to them, they ask for their permission to pass on their name and their phone number into Arthritis Ireland directly, and then it's on us to make the phone call back to them. And then we get in touch with them directly within a few days, give them a bit of time to come to terms with it, and then we have the opportunity then to offer them the full suite of services within Arthritis Ireland. So then they're getting the reliable information from ourselves, they're getting all the knowledge that they need, but they're also getting the support at the right time. So the right place, the right time, the right person. So they're getting it all there and then from people who know exactly what they're going through. They've been diagnosed themselves at some point, so they know what that person is feeling. And then once they've had that initial conversation, they can offer them all of the self-management courses, so the living well with arthritis. If there's someone that is interested in activity and exercise, they can be plugged into the Be Active with Arthritis courses. If there's someone that it's a bit further along in their journey, maybe they've already done the living well course, but they're just having a tough time at this point, and they're having a flare, and they're beginning to wonder what they can do, they might be able to do the mental health course, the Behind the Pain course, so that they can be plugged into all the different services that we have to offer by having the referral coming directly into Arthritis Ireland. And it takes all the pressure off the patient having to do it, and it means that we are the ones that are going out to there, and we're at the right time whether it's the newly diagnosed or someone who's been living with it for 20 years and they're just having a tough time at this stage and they need some support. And then it also takes the pressure off the clinicians and the nursing staff who are dealing with medical queries. What's my medication? How often should I take it? How do I take it? They often don't have time to talk about what do I do with my family and how do I talk to them about it? How do I explain to them that I have arthritis? Whereas we do within the office, within Arthritis Ireland, we have the time to go into those day-to-day lifestyle issues. So that's where it's hugely beneficial. And I really feel it's going to be a huge game changer, if that's not an overused term at the moment, that it's going to really change things for both the clinics and for people that are living with arthritis, to be offered everything when they need it at the point of contact that they have.
Yeah,
Thank you, Peter. You've explained it really well there. So you might be flooded now next week with.
I hope so. I hope so, because
could be very busy.
Yeah, that's what I want. Yeah.
Can I feed back? How much support that gives us as clinicians. I mean, what people often forget is that most departments are really small, and they think that somebody could pick up the phone and answer a lot of these queries quickly. But your nurse might be in a clinic the whole morning seeing patients, and they can't get to the simple messages quickly. And the ability for patients to contact the helpline and get simple advice, when something might be straightforward but it's stressing them, really helps us, because we can't in hospital provide rapid access helplines ourselves. It's very difficult.
Yeah. Okay. Right, so we're actually going to move to the question Q&A part of the session now. And I see we have our first question in there. So the question is, do we need to educate people more to recognize the symptoms of arthritis and get them earlier treatment to ensure better outcomes for patients?
Can I answer
Geraldine, would you like to take it?
I think people are pretty good at knowing when there's something wrong, actually. I think we need better education of doctors in medical school. Rheumatology isn't a core subject, so a lot of people don't get much rheumatology training. And then, so when somebody goes to a GP, for example, they may or may not recognize, I don't, like some of them will, but some of them mightn't. Or they might misdiagnose somebody and send them into us when they didn't really need to. And it's not their fault, it's just that it's not an important enough topic. And then in terms of people specialising in rheumatology, because they're not getting exposed in medical school or indeed as trainees, I don't think we've enough people appreciating that it's one of medicine's best kept secrets, actually. It's a wonderful specialty, it's really interesting. So I think we need to educate. I think the patients are pretty good, it's all the other people are the problem. That's my personal view now. Maybe, David, you might look at it differently.
Our audience agrees.
Yeah.
So do you think that the delays, let me see. I can't see that there now. Oh, it's coming. It's coming.
For patients in terms of their treatment.
It's coming on.
So do you think that the delays in the health system are having an impact on outcomes for patients in terms of their treatment?
Okay.
David, do you want to?
Yeah, I mean, just to follow on, it's kind of interesting, the comment you made about being in clinic, and we're trying to get junior doctors into clinic to get them interested in our specialty and train them. And unfortunately, they're the people who ask you to tell your story again for the 14th time. And I was that doctor once who asked you to tell your story, for the 20th time. And that's how I learned and got interested in rheumatology. So just to kind of bring that back is, that we really want to get GP trainees into our clinics big time, because they really are going to deliver so much of this care for osteoarthritis. So the delays issue, I mean, I don't want to say that there aren't delays, there are delays, but we do tend to always look at the negative side of everything we do in health. As we've tried to say is, once you get in, the treatments are good, and we can do a lot with treatments. We are trying to reduce the delays into rheumatologists. We've got a backlog from the pandemic. As general physicians, rheumatologists were busy during the pandemic, clinics were shut. We had to resort to telephone consultations, which we didn't find as good as we'd like either. And there's a backlog now in the system that we're trying to work through. And so there are long waits again, and so that's why we're trying to create fast-track pathways for inflammatory disease, and we're working with the back pain pathway as well nationally, so fast-track for people who might need surgery urgently, fast-track for people who might need a biologic urgently, and try and manage lots of straightforward back pain with what works, which is physiotherapy and analgesia. So we are trying, but yes, they impact on outcomes. You know, if you don't get people in at the right time with certain conditions, you get a worse outcome. But we are getting a lot of people into the system, and we are treating a lot of people, and we are getting way better outcomes than I thought I'd ever see.
And we triage people.
Yeah.
If a GP contacts me and says somebody is on fire and very sick and everything, we'll see them that same week. You know, so it's not that bad.
Yeah.
But sometimes pain, it's difficult, isn't it? Because sometimes the person in pain may not have an inflammation, but they may have a lot of stress, anxiety, lots of things going on. And it's trying to sift out what we can make a difference with and what maybe the GP can make a difference with is tricky. And that can
actually, our next question is about severe pain. So, you know, what can people do if they have severe arthritis and are managing severe pain and don't feel like they can make lifestyle and dietary changes?
Do you want to answer that?
I think that's been handed over to Peter.
Speaking as an expert.
It's your turn.
Yeah, it's my turn. Yeah. I will say this. There was a time when I didn't feel I could make any lifestyle or dietary changes. I felt I had a good diet and I was managing well. And I do think there is always something. There is always something that you can do. And I didn't say it earlier on, but I think it's important to note, you know, when we were talking about obesity and that, there are people that, you know, who are on steroids and feel that it isn't their fault, and there's a lot of difficulty with getting that activity and movement, you know, for people who feel that it's not through their doing that they may be feeling overweight or obese and things like that. And that can be for various reasons. And then how do they get the motivation then to change? Because it's not necessarily through their overeating or lack of activity that they're feeling that way. If they've been on steroids for a long time and they get the old munchies at 3 o'clock in the morning and you're eating porridge like I used to do and putting on the weight. So it is that. But there's always something that you can do, I feel. You know, whether it's a change to home cooking when you're feeling good and freezing those so that you have a good dinner in the freezer that you can take out on the days that your hands aren't great or that you're feeling really tired, so that you're not going to the takeaways that are everywhere. If it's walking up the stairs rather than taking a lift, if you have that option, you know, they're just small, but as we've said, small little changes built and built and built and built will make a difference. So while whoever asked the question may feel that they can't do anything, if you start very, very small, it will grow. And, you know, as I say, I believe that I couldn't, you know, I played bad golf and played football very well when I was diagnosed. I'm back doing both of those things, but I didn't go back to doing both of those things overnight. I started with walking to the edge of the driveway and to the gate and coming back. Then I walked a little bit further. Then I walked a little bit further. You know, it was literally that, as you said, how do you eat an elephant one bite at a time? You know, it really was slowly, step by step, and it's the same. You didn't put on the weight overnight. It doesn't go away overnight. You know, you can't get a quick fix, so you do have to put the work in.
Thank you. Yeah, I think that's actually
Beautifully said.
Yeah.
Yes.
Peter.
Okay, so a related question in relation to kind of, I suppose, healthy eating. What does the panel think about prescribing obesity control drugs for weight loss?
Well, they're going to be a big improvement, but they have to be part of, you can't skip past the lifestyle changes. I mean, you know, if you don't make the dietary change, these drugs aren't going to work as well as you'd like if you don't make the exercise change. And just as Peter said, I think we're a great race for New Year's resolutions that don't work. You know, we set sometimes too big a target but it's the small steps, small eating changes, small exercise changes, small targets on your watch, and give yourself credit for the small things as well, rather than always being so negative and saying, oh, I didn't achieve this big goal.
Yeah.
And then you'll get to the big goal.
Yeah.
Those drugs, Ozempic, semaglutide, they're available now. They're going to be very useful in dealing with obesity, but only as part of the overall package.
Yeah. Yeah, I think that's very important what you said about the New Year's resolutions. Obviously, we're at that time of year when people might be thinking about it as well. And it's one of the central things that people learn on our Living Well with Arthritis self-management program is all about, setting a goal. And lots of us, set goals in the new year, but we actually don't think about how to achieve those goals. So, I think, Peter, you highlighted it there about, setting a goal, maybe to be physically active or to lose weight, but you actually have to think about, well, how am I going to achieve that? And it is about the action and the plan to achieve that goal, rather than just saying, I want to achieve that goal, and not having a plan as to how you're going to get there.
And also to reward yourself or to congratulate yourself at each step of the journey. I've said this before at other talks. When I was at my worst, I had a little note beside the coffee mugs, and it just said, well done on getting out of bed today.
Great. Yeah.
It started my day with a positive, because I was struggling and I needed that bit of boost. Reward yourself and congratulate yourself for each little achievement.
Yeah.
And Peter, can I ask you, I kind of have a feeling that if a person would have a coach in their life, that it might be helpful. Another person that I've often had people come into me, and we've had the weight conversation, for example, and they said, well, actually, my wife is talking about that too, so we're going to do it together.
Yeah.
Do you see a role for that in all sorts of arthritis, or just somebody working with you to help you?
It's always important to bring somebody with you, whether that's into your appointments so that they can hear what you don't, or it's to bring them along with you on your journey. Having someone with you there is just is huge, and doing it for somebody is also. I found myself, it might not necessarily be doing it for myself. As I say, back in the day, when I was really struggling, I had two little nieces at the time, and I was doing it for them. That was my goal, is to be there for them. Now I've got my own family, and it's all for them. That's what I do it for. And to make sure that nobody or gets into the same position I was when I was diagnosed. That's it.
And I think on that hugely positive note, we're going to finish our discussion. I'd like to thank Geraldine, David and Peter for being here today. I think it's been a really, really interesting discussion. And I hope everybody's enjoyed it here in the audience and watching online as well. So thank you all very, very much.
Thanks.
Thanks, Peter.